There is a moment that happens quietly in the body after 60, and most people never feel it. The same pill you've been taking for years, the one your body tolerated without any issue, can suddenly begin to behave differently. Not because the pill changed, but because your body did. And in some cases, that difference is not small. It can mean the difference between protection and risk, between stability and a slow build-up towards something far more serious, like a heart attack or stroke. What makes this especially dangerous is that nothing feels wrong at first. No warning sign, no pain, no clear signal, just a silent shift happening beneath the surface. And today, we are going to talk about 5 specific types of medications that, after the age of 60, have been linked to an increased risk of cardiovascular events, especially when certain conditions are present, or when they are taken the same way they were years earlier. But here is the part that matters most. This is not about fear. This is about understanding what is actually happening inside your body, so you can make sharper, more informed decisions going forward. My name is Dr. Daniel Morgan. I am a medical doctor and physician, and on this channel, I break down complex health topics into clear, practical explanations, so you can better understand what may be happening inside your body and what actually makes a difference over time. If you find this kind of content valuable, subscribe. But more importantly, stay with me through this conversation, because one of the medications we will cover today is taken daily by millions of people and almost never questioned. Now, to understand why these risks increase after 60, you have to start with something most people are never told. Your body does not process medications the same way it used to, and this is where everything begins to shift. As we age, several critical systems in the body begin to slow down. The liver, responsible for breaking down many medications, becomes less efficient. The kidneys, which filter waste and excess substances from the blood, lose some of their filtering capacity. The result? Drugs stay in your system longer, sometimes much longer than expected. And when that happens, even a standard dose can begin to act like a higher dose over time. But that is only part of the picture. There is also a fundamental shift in how your blood vessels respond. Your arteries become less flexible. The inner lining of your blood vessels grows more sensitive to stress. Circulation patterns change. The balance between clotting and bleeding becomes more delicate. So when a medication interacts with any of these systems, the effect is amplified, sometimes significantly. And this is where people get misled, because the medication itself is not necessarily dangerous. It may have been completely appropriate when it was first prescribed. It may even still be useful today, but the context has changed. And in medicine, more than most people realize, context is everything. The same drug can be protective in one situation and harmful in another. The same dosage can be appropriate at 50 and excessive at 70. And yet, in real clinical practice, prescriptions are often continued for years without being rigorously reevaluated. Not out of negligence, but because these changes happen gradually, quietly, in the background of daily life. Here is where it becomes more serious. After 60, the baseline risk of cardiovascular events, heart attacks, strokes, vascular complications, increases naturally. That is an established medical reality. But when certain medications are layered on top of that baseline, especially without dose adjustment or reassessment, they can push that risk higher. Sometimes subtly, sometimes significantly, and often without any obvious symptoms until something happens. That is precisely why today's conversation matters. Because we are not just talking about medications in isolation. We are talking about how your body interacts with them right now, at this specific stage of life. And more importantly, what you can actually do about it. Before we go into the first 2 medications, one principle must be clear. Nothing we discuss here means you should stop any medication on your own. That is not the goal. The goal is awareness, because when you understand how something works, you ask better questions. You have more precise conversations with your doctor. You stop running on autopilot with something that may need adjustment. And that is exactly where the first layer of risk begins. Because the first two medications we are going to examine are among the most commonly used after 60. They are taken daily. They are widely considered safe. And yet, under certain conditions, they can quietly increase strain on the heart, alter blood pressure in the wrong direction, or compromise how blood flows through already sensitive vessels. Once you see how that mechanism unfolds, you will understand why this is not just about the pill. It is about timing. It is about dosage. It is about the body you have today, not the one you had a decade ago. Let us start with the first one, a medication many people take without a second thought, often for years, sometimes for decades. And yet, after 60, it begins to behave very differently inside the body. The first category is nonsteroidal anti-inflammatory drugs, NSAIDs. This includes medications like ibuprofen, naproxen, and certain prescription-strength anti-inflammatory drugs. They are widely used for joint pain, back pain, arthritis, and everyday inflammation. For most people, they feel like a simple, harmless solution. You take one, the pain eases, you continue with your day. But inside the body, something else is happening. NSAIDs work by blocking specific enzymes involved in inflammation. That is what reduces pain. But those same enzymes also play a protective role in your blood vessels and blood flow regulation. And here is where the problem begins. After 60, your blood vessels are already less flexible. The inner lining of your arteries has become more sensitive to mechanical and chemical stress. When NSAIDs interfere with that protective system, they can trigger a subtle tightening of blood vessels, an increase in vascular resistance. That tightening drives up blood pressure. Not always in a way you notice immediately. It can be gradual, quiet, persistent. At the same time, NSAIDs affect how the kidneys regulate fluid balance. They can cause the body to retain more sodium and water, and that creates additional strain on the heart. Now you have two processes happening simultaneously: elevated blood pressure and increased fluid load. For a cardiovascular system that is already working harder after 60, that combination carries real weight. Multiple large-scale studies have confirmed that long-term or frequent use of NSAIDs is associated with an increased risk of heart attack and stroke, particularly in older adults and those with existing cardiovascular risk factors. And this is where people get caught off guard. The relief is immediate. The harm accumulates slowly. You do not feel your blood pressure rising in real time. You do not perceive the added arterial strain day by day. But over months and years, it builds. Let me be direct. This does not mean NSAIDs are inherently dangerous. It means they require deliberate, informed use. Short-term, carefully monitored use may still be entirely appropriate. But daily, long-term use without reassessment after 60, that is where the risk profile begins to shift. Now, the second medication, and this one is even more underestimated. It is a class of drugs called proton pump inhibitors, PPIs. Examples include omeprazole, esomeprazole, and similar acid-reducing medications. They are commonly prescribed for acid reflux, heartburn, and stomach protection, particularly in people taking other medications that may irritate the gastric lining. On the surface, they appear harmless. They reduce acid, they relieve discomfort, they protect the stomach. But here is what most people are never told. Stomach acid is not just an inconvenience. It plays a direct role in absorbing critical nutrients, especially magnesium, calcium, and vitamin B12. Long-term PPI use gradually reduces the absorption of these nutrients, and that matters far more than most people realize. Magnesium plays a central role in cardiac rhythm stability. Low magnesium levels increase the risk of irregular heart rhythms, arrhythmias that, in some cases, become dangerous. Calcium balance directly affects vascular function, and vitamin B12 is essential for maintaining healthy blood vessels and nerve integrity. When these levels are disrupted chronically, the cardiovascular system becomes progressively more vulnerable. But there is another layer to this. Research has suggested that prolonged PPI use may also impair the function of the endothelium, the inner lining of blood vessels. That lining is critical. It controls blood flow, regulates clotting, and manages vessel relaxation. When endothelial function is compromised over time, the risk of vascular events increases. None of this happens overnight. It builds slowly, quietly, and almost always without obvious symptoms. And here is where the critical mistake is made. Many people are started on a PPI for a short-term issue, reflux, stomach irritation, and then continue taking it for years without any reassessment, because it feels safe, because it was prescribed, because nothing seems wrong. But the longer it continues without review, the more the underlying biochemical effects begin to matter. And sometimes the solution is not stopping the medication entirely. It may simply be adjusting the duration, confirming ongoing necessity, or exploring whether a lower dose or alternative approach is appropriate. But that conversation only happens when someone asks the right question. Now, what we have covered so far is just the first layer. 2 common medications, 2 distinct mechanisms that quietly increase cardiovascular strain over time. But what comes next moves into a different dimension, because the next 2 medications do not just influence pressure or nutrient balance. They interact directly with how your cardiovascular system functions under stress. And the effects, as I will explain, often build over months or even years, which is exactly why they are so frequently missed. The third medication, benzodiazepines. These include medications like diazepam, lorazepam, and similar compounds used for sleep and anxiety management. They are effective. They calm the nervous system rapidly. They help with sleep. And for many people in later life, they can feel like essential support. But here's what is happening beneath the surface. Benzodiazepines act on the central nervous system, slowing brain activity to produce that calming effect. But they also slow down other systems, including breathing regulation, reaction time, and physical coordination. And here is where the cardiovascular connection becomes important. As we age, the body becomes significantly more sensitive to these medications. They are metabolized more slowly. They accumulate more readily in the system. Their sedative effect intensifies even at the same dose. Over time, this leads to reduced physical activity, less movement, more time spent stationary. And that matters more than most people appreciate, because circulation is movement dependent. When movement decreases, blood flow efficiency drops. The risk of clot formation increases. Oxygen delivery to tissues deteriorates. There is also the breathing dimension. Benzodiazepines can alter breathing patterns during sleep, contributing to shallow respiration or worsening pre-existing sleep-related breathing dysfunction, such as sleep apnea. When oxygen levels drop repeatedly during the night, even modestly, it imposes additional stress on the heart. Chronic nocturnal hypoxia is not a minor issue in an aging cardiovascular system. Now consider what you have: reduced circulation, compromised oxygen delivery, and heightened vulnerability in a cardiovascular system that has less reserve than it once did. And none of this feels dramatic. It feels like fatigue. It feels like slower mornings. It feels like normal aging. But underneath the surface, the system is operating under sustained, unnecessary stress. This is where continuous use without reassessment becomes the real problem. Not the medication in isolation, but the absence of periodic review as the body changes around it. The fourth category, decongestants and stimulant-containing cold medications. This includes products containing pseudoephedrine and various combination cold remedies. These are used for sinus congestion, seasonal colds, and upper respiratory discomfort. Many are available over the counter, and that accessibility makes them feel innocuous. But their mechanism is fundamentally different from what most people assume. Decongestants work by constricting blood vessels. That is how they reduce nasal swelling. But that vasoconstrictive effect does not stay localized to the nasal passages. It extends throughout the body, including the vessels supplying the heart. When blood vessels constrict systemically, blood pressure rises. Heart rate can increase. The heart is forced to push blood through a tighter, higher resistance system. In a younger body with elastic, compliant arteries, this effect is generally tolerated. But after 60, when arterial flexibility is already diminished, that added constriction becomes clinically significant, especially for someone who already has elevated blood pressure or who is on medications affecting cardiovascular function. And this is where combinations become genuinely dangerous. Most people after 60 are not taking a single medication, they are managing several. A blood pressure medication, a pain reliever, something for sleep, and then, during cold season, a decongestant added on top. Individually, each may seem manageable. Together, they interact in ways that compound cardiovascular strain. One raises blood pressure, another affects fluid balance, another reduces the body's compensatory capacity, and the system is left struggling to maintain equilibrium. The triggering event, the moment something acute happens, often appears sudden, but the buildup has been there for months. That is precisely what makes these situations so deceptive. It feels like it came out of nowhere. In reality, it was a gradual accumulation that finally reached a tipping point. Now, the fifth medication. And this is the one that surprises people most. Not because it is obscure, not because it is rarely used. Precisely the opposite. It is taken daily by tens of millions of people, trusted as a harmless preventive habit, and almost never questioned. And yet, after 60, the way it interacts with the body can shift in a direction that increases cardiovascular risk, particularly when it is used without regular, individualized reassessment. The fifth medication is low-dose aspirin. For years, aspirin was broadly recommended as a simple, accessible way to protect the heart. A small daily dose, often called baby aspirin, was believed to help prevent heart attacks and strokes by reducing platelet aggregation and clot formation. And in certain clinical contexts, that is still accurate. For individuals who have already experienced a heart attack or stroke, or who carry specific high-risk profiles, aspirin can serve a genuine protective function. But here is where the science has shifted, and where many people have not kept up with that shift. More recent, rigorous research has demonstrated that for many adults over 60 who have not had a prior cardiovascular event, routine daily aspirin may not deliver the benefit once assumed. And in some cases, it actively increases risk. Here is the mechanism. Aspirin reduces the ability of platelets to aggregate, which helps prevent clot formation inside arteries. But clotting is not purely harmful. It is also a vital protective mechanism. The body depends on it to stop bleeding when vessel walls are damaged. After 60, blood vessels become more fragile. The lining of the gastrointestinal tract becomes more vulnerable. The delicate equilibrium between clotting and bleeding tilts more easily. So when aspirin suppresses clotting capacity in this context, the risk of internal bleeding increases, particularly in the stomach or, more critically, the brain. Now consider this carefully. There are two primary types of stroke. One caused by a clot obstructing blood flow, ischemic stroke. Another caused by bleeding within the brain, hemorrhagic stroke. Aspirin can reduce the risk of the first type, but it can increase the risk of the second. And after 60, without a documented cardiovascular history, that risk equation can reverse. In some individuals, the bleeding risk outweighs the protective benefit. This is precisely what more recent clinical guidelines have begun to reflect, a significant departure from recommendations that were standard just a decade ago. And here's the deeper issue. Many people began taking aspirin years ago based on older guidance and simply never stopped. No reassessment, no updated risk calculation, because it felt like a safe, responsible, preventive habit. But medicine evolves. What was once standard practice is not always the optimal approach today. This does not make aspirin harmful in an absolute sense. It makes it specific, dependent on the right indication, the right risk profile, the right individual. Taking it without that clarity does not provide protection. In some cases, it adds risk without meaningful benefit. Now, here is where control returns to you. We have examined 5 medications, each with a distinct mechanism, each affecting the body in a different way. But they share a common thread. Their risk increases when they are taken the same way, despite the fact that the body they are interacting with has fundamentally changed. That is the core insight, and it is the foundation of everything practical that follows. First, review your medications proactively and regularly, not only when something goes wrong. Ask your physician or pharmacist directly, do I still need this at the same dose? Has my risk profile shifted? Is there a safer alternative given where I am now? That question opens a different kind of conversation. Second, take combinations seriously. Many of the risks we have discussed do not arise from a single drug in isolation. They arise from how multiple medications interact, including over-the-counter products and occasional use. Everything counts. Everything needs to be part of the conversation. Third, train yourself to recognize subtle signals, not dramatic symptoms, but quiet, persistent changes. Increased fatigue, unusual shortness of breath, dizziness upon standing, blood pressure readings trending in the wrong direction. These are often early indicators that something in the system needs adjustment, and catching them early makes the difference. And finally, internalize this principle. Your body is not static. What was appropriate 10 years ago may not be optimal today. That is not a failure. That is biology. And accepting that reality is what allows you to stay ahead of it. Now let me bring this together. The real danger is not the medication itself. The real danger is taking it the same way while your body is no longer the same. After 60, your body is not simply an older version of what it was. It functions differently. It processes substances differently. It responds differently under stress. And critically, it tolerates imbalance less easily. That means even small mismatches, small excesses, small unreviewed interactions can carry a larger impact than they once did. And this is where many people fall into a pattern without realizing it. They continue what has always worked. They trust what has always been prescribed. They follow the same daily routine year after year, not recognizing that the context has quietly shifted. This is not a failure of intention. It is a failure of information. Because medicine does not talk enough about this. Not everything needs to be added. Sometimes what matters is adjusting, reducing, reconsidering. That process of subtraction and recalibration is just as important as the original prescription, sometimes more. When that alignment is correct, when the medication matches the body it is entering, the dose, the timing, the context, it can be powerful and protective. When that alignment drifts, even slightly, that is when the risk begins to build. Think of the 5 medications we discussed. NSAIDs, valuable for inflammation, but capable of elevating blood pressure and fluid retention when used long-term. PPIs, important for gastric protection, but capable of disrupting nutrient balance and vascular function over time. Benzodiazepines, effective for anxiety and sleep, but potentially reducing mobility, altering breathing, and compromising circulation. Decongestants, useful for congestion, but vasoconstrictive and cardiovascularly demanding. Aspirin, protective in the right clinical context, but capable of increasing bleeding risk when used without a clear individualized indication. Each has purpose, each has value, each also has a threshold, a point where the balance tips. And that threshold is not fixed. It moves with age. It moves with physiological change. It moves with the other medications you are taking, with your lifestyle, with your underlying conditions. That is why awareness is the most important clinical tool you have. Because awareness drives better questions, and better questions drive better decisions. At your next appointment, instead of focusing solely on new symptoms or new prescriptions, ask this one question. Is everything I am currently taking still appropriate for me at this stage of my life? That single question shifts the entire conversation, from reactive to proactive, from adding to evaluating, from managing symptoms to optimizing the system. And pay attention to what your body is telling you. Not the dramatic signals, those are hard to miss. The quiet ones, the gradual shifts, fatigue that comes faster than it used to, lightheadedness when standing, shortness of breath during activities that once felt easy, sleep quality that has changed. These are not noise, they are meaningful data. And when you combine that attentiveness with regular medication review, you develop a level of informed control that most people never build. The difference between reacting to a cardiovascular event and preventing one almost always comes down to small, early adjustments. Not one dramatic intervention. A series of informed, deliberate recalibrations that keep the system in balance over time. And here is the reality. You have more influence in that process than you may believe. You may not control every risk factor, but you do control awareness. You control the questions you ask. You control whether your current routine still matches your current biology. That alignment between what you are taking and who you are now is what makes the difference. Not fear, not avoidance, alignment. If this conversation shifted your perspective or prompted you to look at your routine differently, stay connected to this channel, because this is exactly what we focus on here. Not exaggerated claims, not shortcuts. Clear, rigorous, practical understanding of how the body actually works and what genuinely makes a difference over time. And if you know someone taking daily medications, particularly after 60, sharing this with them could matter. Because sometimes the most important changes begin with a single, clear realization. What worked before may need to be looked at again. And once you see that clearly, you begin making decisions from a completely different foundation. Word count, approximately 3,700 words.